Your doctor has just scheduled you for a routine screening. You didn't question it, you never do. But what I'm about to share may change that forever. After more than 20 years practicing internal medicine and working closely with older adults, I can say this with absolute certainty. Some of the tests your doctor orders after age 65 are more likely to harm you than help you. And most doctors won't say that out loud. I'm Dr. Lina Laurent. I've dedicated my career to helping patients over 60 navigate one of medicine's most confusing areas, knowing when to act and when to leave things alone. Today, I need to share something that goes against everything you've probably been told about preventive care. There are four routine medical checkups I would avoid after age 65, not because I don't believe in medicine, I do, but because I've seen time and again what happens when these tests uncover something in a 70 or 75-year-old body. And the outcome isn't always what you'd expect. Before I walk you through each one, you need to understand a key concept. It will change every medical conversation you have from this point forward. It's called the cascade effect. Here's how the cascade works. You go in for a routine test. The test finds something, that something looks like it might be a problem. So your doctor orders another test for a closer look. That test finds something slightly different, leading to a specialist referral. The specialist recommends a small procedure, just to be sure. The procedure causes a complication. The complication requires treatment. And 6 months later, a person who walked into the clinic feeling completely fine is now managing 3 new diagnoses, taking 2 new medications, and is less functional than when it all began. I've watched this exact sequence unfold more times than I can count. Not because doctors are careless, but because medicine is designed to find things. And once something is found, the system is built to respond to it. The problem? Not every finding in an older body needs a response. Here's another thing you need to understand. Most medical guidelines were developed using research on younger adults. They were then extended to older patients without specific evidence for that age group. The risk-benefit calculation that makes a test sensible at 50 can look completely different at 70. And that recalculation almost never happens in the room with you. Let me tell you about a patient I'll call Theodora. Theodora was 73, a retired teacher, active, independent, and mentally sharp. She went to her annual checkup feeling completely well. Her doctor, following standard guidelines, ordered a full suite of routine screens. One of those tests, one I'll name shortly, came back with an abnormal result. What followed over the next 9 months was a cascade no one planned or predicted. 3 more tests, 2 specialist referrals, 1 minor procedure that caused a minor bleed. The bleed required monitoring, the monitoring required medication. One of those medications caused dizziness, and Theodora, who had been completely independent, fell in her bathroom and fractured her hip. She recovered, but she was never quite the same level of independent again. The original finding from that first test, ultimately determined to be clinically insignificant. It was never going to hurt her, but the process of investigating it did. We'll come back to Theodora because the question she asked me during her rehabilitation is one I believe every older adult deserves to ask their doctor before agreeing to any screening. Checkup number 1, routine full body CT scans. Whole body CT scanning has been heavily marketed to health conscious adults as the ultimate preventive tool. You get a full scan from neck to pelvis. The machine checks everything, and you walk away knowing exactly what's happening inside your body. It sounds like the smartest thing you could do for your health. Here's the problem. When you scan an entire body at 65 or older, you will almost always find something. Not because something is wrong, but because human bodies accumulate incidental changes with age. Small nodules in the lungs that have been there for decades without causing problems, tiny cysts on the liver or kidneys that are completely benign, minor abnormalities in the spine that are normal structural aging. The medical term for these findings is incidental, discovered by chance, never causing symptoms, and never going to. But here's what happens when the scan report comes back with those findings. Your doctor is legally and professionally obligated to investigate them. So the cascade begins. A lung nodule means follow-up CT scans every 6 months for 2 years. That's a significant radiation dose accumulating in a body already less efficient at repairing DNA damage. Sometimes the follow-up scans look slightly different, triggering a biopsy. Biopsies of lung tissue in older adults carry risks of bleeding and lung collapse. A study in JAMA Internal Medicine found that whole body CT screening led to further diagnostic testing in 37% of participants, and most of those findings were ultimately clinically unimportant. Meanwhile, the downstream testing caused real complications in real people. The radiation from a single whole body CT scan is equivalent to about 3 years of natural background radiation. At 65, your cells repair radiation induced DNA damage more slowly than they did at 40. Repeated scanning compounds this. The question to ask before any CT scan: do I have symptoms this scan is specifically intended to investigate? If the answer is no, think very carefully before you agree. Checkup number 2: routine bone density scanning after 80. DEXA scanning measures bone density and is used to screen for osteoporosis. For women in their late 50s and 60s, this is genuinely useful. Finding low bone density at that age creates an opportunity to intervene with medication and lifestyle changes that can meaningfully reduce fracture risk over the next decade. But after 80, the calculus changes significantly. Here's what happens when a routine DEXA scan returns an osteoporosis finding in an 80 or 85-year-old patient. The standard response is to prescribe bisphosphonate medications like alendronate or zoledronic acid. These drugs are effective at increasing bone density on future scans. However, research in the British Medical Journal and the New England Journal of Medicine has raised serious concerns about their use in very elderly patients. The first concern is a rare but serious condition called atypical femur fracture. With long-term bisphosphonate use, bone structure can paradoxically become more brittle in specific ways, leading to fractures in the thigh bone with minimal force, fractures that are extremely difficult to repair in elderly patients. The second concern is osteonecrosis of the jaw, where the jawbone begins to die, particularly in older adults who have dental procedures. Here's the broader point. After 80, the goal of preventing hip fractures is best achieved not by treating a scan number with medication, but by directly addressing fall risk. Fall prevention programs, strength training for balance, home safety modifications, and medication reviews to identify drugs that cause dizziness. These interventions have strong evidence for reducing actual fractures. A DEXA scan that leads to medication without a fall prevention conversation is addressing the measurement, not the real problem. If a DEXA scan is suggested after age 80, ask, will the result of this scan change the treatment plan beyond what a fall prevention assessment would already recommend? If you've made it this far, you're clearly invested. You want to see what happens next, but most viewers enjoy the content and scroll away without subscribing. If this resonates with you, tap subscribe. It takes a second. If not, you'll probably forget this channel exists and miss a lot of great educational content ahead. Checkup number 3: carotid artery ultrasound without symptoms. The carotid arteries are the two large blood vessels on either side of your neck that carry blood to the brain. Over time, they can develop fatty plaque deposits, narrowing the artery and potentially causing a stroke if a piece breaks off. Carotid ultrasound is often ordered routinely in older adults as a stroke prevention measure. On the surface, this sounds entirely sensible. Find the problem, fix it before a stroke happens. That logic is appealing, but the evidence doesn't fully support it. Here's the critical issue. The procedure used to treat significant carotid artery narrowing is called carotid endarterectomy, a surgical operation that opens the artery and removes the plaque. This surgery itself carries a risk of causing a stroke during or immediately after the procedure, because disturbing plaque in an artery near the brain is inherently delicate and risky. In patients who've already had symptoms, a mini stroke or TIA, carotid surgery has clear evidence of benefit. But in patients with no symptoms at all, large studies like the ACST and ACS trials found that for asymptomatic patients over 70, the surgical risk of stroke equals, or sometimes exceeds, the stroke risk of doing nothing and managing the patient with medication alone. In other words, the test finds something. The something gets operated on, and the operation causes exactly the event it was supposed to prevent. The American Heart Association guidelines are clear. Routine carotid ultrasound screening in adults without symptoms is not recommended as standard practice, yet it continues to be ordered regularly. If your doctor recommends carotid ultrasound and you have no stroke or TIA symptoms, ask directly. If this scan finds narrowing, what is the stroke risk of the surgery compared to the stroke risk of simply optimizing my blood pressure and cholesterol medications? Ask for both numbers. You're entitled to both. Checkup number 4, aggressive cardiac catheterization after a positive stress test with no symptoms. I saved this one for last because it has the most serious potential consequences. This is the checkup I believe has the highest potential to harm rather than help in asymptomatic patients over 65. Here's how this scenario typically unfolds. A patient over 65 goes for a routine cardiac stress test. They have no chest pain, no shortness of breath, no fainting, no symptoms at all. But the test is ordered routinely as a preventive measure. The stress test comes back with an abnormal reading. The cardiologist recommends cardiac catheterization, a procedure where a thin tube is inserted through an artery in the wrist or groin, fed up into the coronary arteries, and dye is injected to image the heart's blood vessels directly. Catheterization is invasive and carries real risks for older patients: bleeding at the insertion site, arterial injury, kidney damage from the contrast dye, especially serious in older patients with reduced kidney function, and a small but real risk of stroke during the procedure due to tiny air bubbles or plaque fragments disturbed by the catheter. Here's the devastating finding from the Courage and Ischemia trials, two landmark studies in the New England Journal of Medicine. In patients with stable coronary artery disease and no significant symptoms, aggressive intervention through catheterization and subsequent stenting or bypass surgery did not reduce the rate of heart attack or death compared to optimal medical therapy alone. Medication managed these patients just as well with far less risk. This means that for an older adult with no cardiac symptoms, a positive stress test leading to catheterization and stenting may deliver all the procedural risks and none of the protective benefit that medications would have provided anyway. The stress test also has a high false positive rate in older adults, particularly in women. A positive result in a symptom-free patient sets off a chain of events that research suggests may not be necessary and may cause harm. Before agreeing to cardiac catheterization, ask your cardiologist directly. Do I have symptoms? And if not, what does the evidence show about outcomes for people like me who are managed with medication compared to those who undergo the procedure? The answer should be a conversation, not a referral slip. I promised I'd return to Theodora. During one of our conversations after her recovery, she asked me a question I think about every day. Doctor, if I had known to ask one question before that first test, what should it have been? I told her the answer is always the same. If this test finds something, what will we do about it? And is that something worth doing at my age and in my current health? That's it. That single question, asked before any screening, forces the conversation the system isn't designed to have with you automatically. It makes the doctor think about the cascade before it starts. It puts you at the center of the decision. Theodora told me she wished someone had taught her that question 30 years earlier. I'm teaching it to you now. Let me bring this all together with clarity and confidence. 4 medical checkups, worth very careful thought before you agree after age 65. Routine full-body CT scans that find incidental abnormalities, almost guaranteed to trigger cascades of investigation for findings that were never going to harm you, while delivering accumulated radiation to a body that repairs that damage more slowly with every passing year. Routine bone density scanning after 80 that leads to bisphosphonate medications with serious risks in very elderly patients when fall prevention programs have stronger evidence for reducing actual fractures. Carotid artery ultrasound without symptoms, where the surgery triggered by findings can carry a stroke risk that equals or exceeds the risk of doing nothing and optimizing medications instead. Aggressive cardiac catheterization after a positive stress test in a patient with no cardiac symptoms, where landmark trials show that medical therapy alone achieves the same outcomes without the procedural risks that can cause exactly the events you were trying to prevent. None of this means you should avoid your doctor. Let me say that clearly, and I'll say it once. Preventive medicine saves lives, Blood pressure management, diabetes control, vaccination, vision and hearing checks, annual medication reviews, these are valuable and important. What I'm asking you to do is go to those appointments prepared. Bring this question with you, write it on a piece of paper if you need to. If this test finds something, what will we do about it? And is that worth doing for someone my age? Ask it before every screening, every single time. Your doctor will either have a good answer, in which case, proceed with confidence, or they won't have a clear answer, and that itself tells you something important. Which of these four checkups surprised you the most? Tell me in the comments. I read every one. And if you've ever experienced a medical cascade yourself, where one test led somewhere unexpected, share that in the comments too. Your story could help someone sitting in a waiting room right now make a better decision. Share this video with someone you love who is over 65 and goes to every scheduled screening without asking a single question. The most important thing you can do for their health today might be giving them the one question that changes everything. Subscribe for more honest medical conversations that put you in control of your own healthcare decisions. I'm Dr. Lina Laurent. You deserve the full picture. Always. Disclaimer: everything shared in this video is general medical information based on published research and clinical guidelines. It is not personal medical advice for your individual situation. Every person's health history is different, and some individuals may have specific medical reasons why these screenings are appropriate for them despite their age. Before making any changes to your scheduled medical care, please have a thorough conversation with your own physician. This video is a starting point for that conversation, not a replacement for it.